be doing another student webinar tonight. We're on number 34 already. Tonight, we're going to talk about pressure ulcers. I had a question that came in regarding, coding healing pressured ulcers or healed pressure ulcers. And again, when you're first learning, as a student, sometimes that can be a little troublesome. You think of the verbiage and what you see in the documentation, and sometimes it's hard to determine, is this a healed pressure ulcer, meaning there's nothing else going on, or are they still treating it, And so we're gonna talk about that. We're going to talk about a few other things, and then I'm going to show you how to do a little research as well. At the end of this presentation, at the end of the slide deck, if you're a student or you're not watching us just on Facebook or YouTube, or you're in the club, you get to see the resources that I use. And I pulled out a lot of articles and put those in the resource slide at the very end. Take some time to go out there and look at those, and we'll talk about some of the key words that you can use to look in Google and what would be an authoritative site to look at, and sites that you can get the information you want faster versus maybe looking at a blog that you're going to have to, or a Q&A area where you're going to have to really search through something to finally come up with an answer. And then when you look at those, sometimes you have to say, well, is the person that answered the question authoritative? You got like 4 people that answer the question or make comments on it. Is this valid? What's their background? Or is it just somebody that's giving their opinion? And so we'll talk just a little bit about that. But as you're a student and you start getting into the belly of the beast, I guess, and when it comes to research, we'll give a little tip here and there on how to speed things up for you, because you're going to be researching for the rest of your life as a coder. And even if you're doing billing, or even in the medical field, period, you're going to notice that research is a way of life for you. Well, mainly, what are we going to talk about? We're going to talk about what we need to know if we're going to code pressure ulcers. And not only the verbiage, we're going to talk a little bit about the guidelines and the codes that are involved with this, and the documentation from a provider's perspective, from a coder's perspective, and also from a billing perspective, how to look at that. And then I'm going to mention a few things about particular parts of the guidelines that you may see on a coding exam. So we want to make sure we got that. So let's talk about the verbiage itself. So, what is a pressure ulcer? So the authorities on pressure ulcers, there's actually a group that deals with pressure ulcers exclusively, and they state that it's localized injury of the skin and or underlying tissue. Okay. Usually, but not always, it's over a bony prominence. Now, when we say a bony prominence, we're talking about anything that has like a bone, like here at your wrist, right? There's a little bone sticking out here. You know how you get these little bones here that stick out at the end of your clavicle? Well, you're not going to get pressure on that, are you? Because you're not going to be laying on your belly per se. But that would be a bony prominence. Your elbow, your knees, your heels, the heel of your foot, the hip bones, right there at the iliac crest at the top of your hip bones, as well as there on the bottom, they'll use the term buttocks, sacral area. Again, you've heard me probably say over and over again, we need to know the bones, and you do need to memorize the bones. And this is a classic example, because if it's going to be a place of occurrence over bony prominences, then you better know the name of the bone, right? To be able to get the proper location. So it's a result of pressure, or pressure in a combination of shear, which when they say shear, they mean rubbing. So if you've ever had to stay in a hospital for very long at all, as you know, they bleach the sheets, right? And in the past, they used to be like a cotton sheet that was stiff, and now more so it's kind of a softer sheet. I think, but you would move yourself up in the bed and you'd use your elbows to push yourself back up into the bed, especially, when they would put it on a slant, you would sink down to the bottom. Well, that would shear off after a while. The roughness of the sheets would shear off the end of your elbow, take the skin off. So think of it like a rug burn. That would be a shear type thing. Just so we talk about a rug burn being a rug burn because it's friction, but that's really shearing off the top layer of the skin and exposing that to the outside area, outside world. And then if you combine that with pressure, which ultimately gives you lack of circulation, so no blood flow gets to that little prominent area, right? And you have a loss of integrity of the skin. So you get a little break in the skin, and the next thing you know, it looks like a cold sore, right? And then it just starts growing and growing. Okay. Now, this statement, the rest of this statement I got from a particular website that was trying to educate podiatrists on foot ulcers. And it was fabulous. So really, I changed the verbiage a little bit in here because it was as if one provider's talking to another provider saying, this is what you need to do. So again, it's not a provider talking to a coder or coders talking to each other. We have to consider the verbiage that we see in documentation. Now, this is real world, not in testing. Okay, so in real world, the terms wound and ulcer are kind of synonymous, right? So if you have a wound to your elbow, that's what the provider may say, that it's a wound, but then he gives you all the information of a pressure ulcer, what stage it is, what size it is, the location, things like that, and it says wound, right? That's not the way a coder considers a wound and a pressure ulcer or ulcer are two separate things, but not always is that the case for a provider. Okay, and our role as coders is to translate that documentation that the provider has given and into a code set so that we can collect it for statistics and we can also get reimbursement. But that means we have to be aware of what the provider's verbiage is as well as our verbiage, because we're translating it. And then on top of that, we have to educate and be a liaison for that provider to say, like it says in this bottom sentence, that as far as ICD-10 is concerned, a wound and an ulcer are not synonymous. But it is a lot of times when you're out there documenting. The provider thinks because a wound is a wound, right? Just about anything can be a wound. But actually, when we look at a wound, it occurs via something traumatically happening. So if you step on a nail, that's a traumatic injury, right? You stepped on a nail. If you got a splinter in your hand, that's traumatic. If you fell on your elbow, you didn't break anything, but it really messed up the skin and took the hide off of the end of your elbow there on that bony prominence, that's not an ulcer, that's a wound, right? You could have an avulsion wound. An avulsion sometimes can end up looking like an ulcer. Now, can a wound become ulcerated? Yes, it can. But remember, they're two separate things. A wound is traumatic. And if you are sliding every day up and down in that bed and pushing yourself up with your elbows and you develop a ulcer on a bony area, that's not a wound. That is based on pressure and lack of circulation. Okay. Versus if you were to go, smack your elbow on something and take the hide off the end, that's a wound. That's something traumatic. So if you're going to code wounds, those are S codes, right? You're going to find those in the index under S codes. Ulcers, though, are going to be L codes, and they really ultimately mean that you've had that breakdown of the integumentary system. The integrity of the skin has been broken, And it tends to be a chronic thing. It starts out slow and then it builds up into an ulcer. Okay, so when we look at the disease process, even though this is injuries, but we think about how a wound occurs. Okay, if we say a wound is anything that messes with the integumentary system. You know, if we scrape the elbow, of course we've taken off, we've compromised the integrity of the skin because we have an abrasion and avulsion type wound on the elbow, but it's an acute trauma, right? But if we go and we sit there and we rub and rub and rub, then with those elbows on those stiff hospital sheets, that's chronic. That's something that doesn't happen acutely. It's a slow process till it wears down the integrity of the skin. Knowing that, then it's very easily determined who are going to be higher indicators of people that would get ulcers, right? You know, anybody that has chronic repetitious movement or pressure on a bony prominence. And those will be people like quadriplegics, bed-bound people that can't get up, and bed-bound quadriplegics, when you first have an injury and you're paralyzed, that's why they rotate you. They'll put you on a bed where they can literally flip you on your face, and they just sit there and rotate you like a hot dog at the gas station. Got to take the pressure off. So again, L codes, that's ulcer codes. And just looking at the guidelines when we determine what is a pressure ulcer and what's not a pressure ulcer. A pressure ulcer is always going to be coded out at L89, right? So it's going to be a good idea for you later to open up your manual, look in the tabular at the L89 codes. And once you do that, it allows you to become familiar with what you may not have known even existed, the possibilities. And there's some things that are going to be difficult that we'll talk about here on that'll make you go, huh? You know, those things that make you go, huh? I like that. We'll talk about that when we get to dealing with foot. That's another reason why I had looked up podiatry. So other words that are synonymous with pressure ulcers are going to be bed sores. You hear that a lot in skilled facilities, nursing homes, right? Home health. Decubitus ulcer. Now, when you see a pressure ulcer, they will abbreviate it as a PU, okay? Don't get it confused with a PE. That's a pulmonary embolism, okay? Even though I know it's the second letter is different, just when you look at it, you got to think, no, that a PE is a pulmonary embolism, a PU is a pressure ulcer. So a bed sore, a decubitus ulcer, they call them DUs or decube. A lot of times they'll abbreviate decube, and then you know a decubitus is a decubitus ulcer. We have plaster ulcers, pressure area, and pressure sore. Again, the two terms besides pressure ulcer that you're going to see the most is going to be decubitus ulcer and bed sore. So bed sore is more of a layman's term, like saying your collarbone, it's your collarbone and not your clavicle, but it still means the same thing. Okay, but decubitus is probably after pressure ulcer the most common verbiage that you'll see. It's very important though that a heads up, and these are things that you could be tested on, is knowing if that ulcer has developed gangrene. Now, let's think about the disease process of gangrene. Whenever you have a lack of circulation, you have a warm, moist, dark spot that leads for that infection can occur, right? There is a possibility of getting gangrene. And then throw in the fact that a person could have other conditions like diabetes. I was telling them at HealthCon when I went there this last week that think about when you make bread, You know how you want your yeast to rise and activate it? What do? You put it in the warm water, that activates it. But if you want to speed up the process, you go ahead and you throw the sugar in on top of that yeast, right? Because the yeast feeds, the warm water activates it, and the sugar feeds the yeast. It works the same way with a wound. Okay, if it's not going to be an area that can be exposed to the air, it can dry out and let the natural healing process happen. And what happens with a pressure ulcer? It's pushed against the skin, and whatever is being contacted, say that bed or that sheet, it's you sweat, you get that constant pressure, so there's not good circulation, and it's dark, so you got a warm, moist, dark spot, right? And then you throw in the person having diabetes. So again, pressure ulcer L8-9, but there is an excludes too that you want to consider. One, we need to know if there's gangrene involved, and if there's gangrene, then we're going to jump over and first code that the person has gangrene, I96, okay, and then the L code, right? Because gangrene is going to definitely result in amputation. Now you think, well, how do you amputate? Right here, gangrene, they go in and literally remove the tissue. So they don't amputate like cutting something off, but they are going to debride that down. We got to have help. We got to have all the infection, all the gangrene out of the area. We've got to clean it, debride it, and let viable tissue take over. Okay, gangrene results in death of tissue, necrotic tissue with infection. The excludes too. We want to pay attention. Look at the same word, decubitus, or trophic ulcer of the cervix. Okay, so if you go and you look up decubitus in your index, you're going to get this. Well, you don't get a pressure ulcer of the cervix. So that's an N code, N86. The other thing that you need to be very aware of is diabetic ulcers. Diabetic ulcers and pressure ulcers are completely two different things. Now, can they be the same thing? Yes, they can still be a bed sore, but if the patient is a diabetic, it is now a diabetic ulcer, right? Now, in the past, before your time, as a coder, you used to have causal verbiage to associate that this bed sore, that the patient's diabetes attributed to this bed sore. But now that you don't have to do that anymore. And we're going to use some clarification here on another slide. Just be aware that if the person has diabetes, doesn't matter if it's type 1, type 2, if they have diabetes, it is not an L89 code. It is an E code, depending on what type of diabetes they have. So if they have type 1 diabetes, it's going to be E10.6, because the 6 is the integumentary system as a manifestation of having complication. Or it's going to be an E116. Again, E11 is going to be type 2 diabetes. And then we have, of course, E08, E09, and E13, and those are other types of diabetes. Pay attention to non-pressure chronic ulcer of the skin. A person can have a chronic ulcer of the skin and it not due to that pressure on that bony prominence. Right, so be very, very careful of that. Skin infection. Say a person has a skin infection and develops an ulcer, not a pressure ulcer. And there's also a varicose ulcer, and this has to do with the cardiology, cardiovascular system together. So in other words, we have varicose veins that are, we're not getting good oxygenation. There's a problem with the varicose veins getting the blood back, and the skin ulcers. Okay, that's going to be an I code because it has to do with cardiology, cardiovascular system. It's very important that you understand. Don't worry about the chapters that these are found in. It's that first character. So L, whenever we do L, you're thinking skin. E, endocrine system, diabetes. Okay, I, cardiovascular system. So we can think of the disease process and what body system we need to be in. let's talk about the division of pressure ulcer. So I told you a pressure ulcer is going to be an L89 code. Now, do you have to have that memorized? Not necessarily, but it would be a good idea to maybe write that down in your manual someplace that just, says PU equals L89, so that if you need to go and look something up real quick, you can, or if you're looking at your testing and you say, oh, there's an L89 code here, that tells me that this person's got to have a pressure ulcer. Okay, and kind of speed up. Again, you don't have to have the stuff memorized, but if you can reference it quickly, that's a good thing. We do have a question, and I'm going to take that. I see it over there, but I'll look at it here in just a minute. Just letting you know. Good. Okay, so that's a question from Whitney. I did see it, and I'll do it after this slide. So pressure ulcers are divided up into more than one thing. We identify that it's a pressure ulcer, that's going to be an L89. But if we have a pressure ulcer, we need to find location. And these are the common locations of pressure ulcers. So I mentioned elbow. So that's going to be an O, a point O. Pressure ulcer of the back, anywhere on the back would be a 0.1. The hip, now think of the bony prominence of the iliac crest is going to be the hip, so that'd be a 0.2. Pressure ulcer of the buttocks. Okay, now that is, you have to understand where that is. That's the fatty portion, part of your backside, right? And you're often laid on your back, so of course you're going to have a pressure. You can have a pressure ulcer there. I made this a smaller print because I want to get it all on one line. 0.4 is going to be continuous site, back, buttock, and hip. Well, what that means is we have a pressure ulcer that encompasses all that area, right? So what if you have a pressure ulcer that's on the hip and the buttock? What are we going to do? Are we going to code for the hip and the buttock? No, you've got a code 0.4 that says if it is on the back, buttock, and hip, all right there, we can code that together. Okay. Then again, the ankle, the bony side of it, like this part of the ankle, you're laying on your side, that can rub. The heel, very, very popular place to have the ulcers. In fact, they used to roll up a blanket, and if you were laying on your back, a bedridden person, they would elevate the feet and put that blanket roll under the ankles to keep the heels up off there, because this part of the heel, it's that constant pressure. And the integumentary system of an older person anyway is compromised usually because cardiovascular system isn't as good as it used to be. And then maybe they've lost a lot of weight. Doesn't matter if they've lost weight and have really bony ankles, or if they're obese and have the fat also compromises the integrity. So it doesn't matter what size you are. Now note, here we have pressure ulcer of other site and pressure ulcer of unspecified site. Let's break that down. First, let's start with unspecified site. What that means is we have documentation of a pressure ulcer, but we haven't identified where the pressure ulcer is located at. There's a reason for this. Maybe we can't visibly get in there and see where it's at yet. Okay, these are codes that you see a lot of times in the ER before the provider comes in, and you think that it's you've got a pressure ulcer, and they are going to identify it, but the documentation hasn't gotten back and things like that. Unlike unspecified, unlike other, means that it's not on this list. All right, why do we have elbow, back, hip, buttock, ankle, and heel? Because that is the most common places for pressure ulcers to occur. A pressure ulcer can I've seen them on the back of the head, because quite honestly, your skull is bony, right? You've got a lot of blood in your cranium going around the cranium, and that pushes against that thin layer of skin, and you can get an ulcer on your head. But what would that be? Well, that would be other, because it's identified. We know where it's at, it's specified, but it's on the back of the head, so that would be classified as other. It's not in our list. What about foot? Where do you classify foot? Because we have ankle and heel. Well, we're going to tell you about that in just a minute. because that's one that you're not going to be tested on that, but it gets very confusing for everybody. Okay, let me look at Whitney's question real quick, and then we'll do the cause and related factors. If a patient was discharged from the hospital, says like on Tuesday, and they come to the ER Thursday complaining of pain in the left buttock, do you assume it was a hospital acquired? I didn't know for sure how long it takes for a pressure ulcer to develop, and the patient was in her 20s, so she was young, manage like show more reactions. Oh, wait, okay. The age is not a differentiating factor for pressure ulcers. However, we don't assume young people get pressure ulcers unless they are maybe in a wheelchair. Okay, maybe they have an amputation like a BKA, and they use their you can get pressure ulcers of the end of the stump. So now they use like a neoprene sock that they'll put on there to help alleviate that, and they've done a much better job of making the fitting device that goes around an amputation to your prosthetic, things like that. But anytime you have a prosthetic, you could develop a pressure ulcer, and that could be a young person. But usually 20, a person that's the age 20 is, you're not going to see that unless there's some other comorbidities going on. Are they diabetic? Why were they in the hospital to begin with? Things like that. Now, to answer the question is it hospital related? This is a good question, because when you code for inpatient versus outpatient, the principal diagnosis is really important. And this is something that statistically is tracked very carefully, and it has to do with reimbursement too. So if something is acquired while they're in the hospital, they don't get reimbursed for that. Okay, so if you have a person, I think the example we're going to see in a minute is a person has pneumonia, and they're in the hospital, and then they develop a pressure ulcer. The hospital doesn't get reimbursed for that pressure ulcer because it was a hospital acquired pressure ulcer. So you can imagine this makes a big difference. Now, our patient was discharged. To answer that is, you never assume it's a hospital acquired pressure ulcer. It has to be documented that it was. So if it does not say that it was a hospital acquired pressure ulcer, you will not code it that way. So if you even have to question, you can query the provider, of course, but you're looking at an ER report. And unless the ER physician can clearly define that as a hospital related pressure ulcer, maybe the patient came out on a Thursday, right? And you said that Tuesday, and they went to the ER on Thursday. Maybe they had so many pain medications from their surgery that they stayed in bed for 24 hours straight and didn't toss and turn because they were practically comatose on their pain meds, and they sweat and lack of circulation. Is the person obese? Is the person very skinny? Did they have a comorbidity like a diabetes, that complicated the skin integrity? Things like that. They could definitely develop a pressure ulcer within that short of a time. A pressure ulcer can develop incredibly quickly, and that's why there's protocols and skilled facilities. You can go look at a patient one day, look at them, and you think maybe you saw some redness there, and anytime you see anything like that, you're definitely going to comment and mention it and document it in the nurse's notes. But so you turn the patient and you pay attention, and then the next day you come in and the skin has been compromised and is split open. One of the things about pressure ulcers is sometimes you can't see what's going on underneath that top layer of skin. So the skin may have already broken down under here, and this top area still has its integumentary system is still intact. Sometimes it could turn black, sometimes it's not, it's just red, but then you go and you touch it and you realize, oh man, have you ever touched a soft, bad apple? And you're like, ooh, something's gushy underneath there. The pressure ulcer has already developed, it just hasn't broken the top layer of skin yet. Okay, so again, until you get in there and look in and examine it, you may not know. All right, so I hope that answered your question. Now, what is causes and related factors? We've already mentioned a few things, but this leads into what Whitney stated. The specific cause has to be documented, right? And you cannot assume as the coder if it is associated to something else. Now, in the past, I mentioned diabetic ulcers versus pressure ulcers were separated and had to have the documentation. That isn't this, we have causal effects have changed in, what was it, 2017, I think, 16 and 17. So whenever you look at an article, pay very close attention to the date the article was written. The article that I pulled this information actually came from 2009 for that change in the guidelines. So I adjusted. I took out some of the comments that went into the article because it wasn't applicable for today. So when you go and you reference that, I made a point on the reference to say, hey, this was a 2009 article. So that's a heads up. You're going to see things that were applicable in 2009, but the guidelines changed. And so always be aware of that. So that's a tip about doing research. But the fact doesn't change that you cannot assume a cause and an effect relationship in a disease process with skin ulcers, right? The guidelines have changed with diabetic ulcers, but this is really applicable when we talk about hospital, them getting the pressure ulcer at the hospital due to that. But again, this patient was discharged before they had the signs and symptoms, so I don't think you're going to be able I don't think that ER provider or anybody's going to link that for you. Definitely for diabetic ulcers, heads up, because you need to be aware of what could cause a diabetic pressure ulcer. You could have neuropathy, peripheral neuropathy. So neuropathy runs off the nervous system, right? And so we don't have good information there to relate from the site up to the brain saying what's going on. You could also have PVD, which is peripheral vascular disease. So our vascular system is compromised peripherally, outside, away from the heart. Or it could be combined. They could have PVD and atherosclerosis, right? Though whenever a person has these conditions and they're diabetic and they have a pressure ulcer, then you're going to see these due to. And that means that we're going to use different diabetic ulcer codes. Some of the characters are going to be different. So that's a heads up. Healing of pressure ulcers. I wanted to make sure that you are aware of this because quite honestly, let me move this down here, make sure I think I got another one. This was a question, remember I told you the blogs and stuff, you got to be careful. This one was really informative. And so, and again, the link is down there so you can go to it. It says, would a pressure ulcer be considered healing when the patient comes back to an outpatient setting? And this goes to the question that prompted us to discuss this tonight. The person stated they were having trouble understanding if something was a healing or a healed pressure ulcer. And I loved this answer. So the answer says, this is what you have to ask yourself, because this is what I say to people all the time when you get ready to pick a coach. Like, ask yourself a few things. One, has it completely healed or is it still healing? Okay. Now that seems, well, of course. Well, I can't figure that out, right? Say, I've looked at the documentation, I can't figure that out. That's the first thing that you have to look at, because maybe there's just a little bit of a gray area in the documentation that you can't tell if that this is healed or it is a healing. Now, we'd like to say we never run into this, but quite frankly, you do. You are not going to experience this when you're testing because they aren't going to give you any guesswork. That's not what they're testing you on. They're testing you on the guidelines when you take a certification exam. So there's no tricky stuff. They're not trying to do that. However, you could get a question that talks about healing or healed, right? But they're going to make it blatant for you. And of course, we can always query the provider, but if it states that it's a healing ulcer under active treatment, that's that means it's not healed. Okay, active treatment means it's not healed yet. Also, a healed ulcer doesn't get coded. So if you have a healed ulcer of the elbow, but the patient is coming back to follow up on that healed ulcer to make sure that it's, still looks good, then you're not coding a healed ulcer, because we don't code healed ulcers, right? You could use a history code, or there's not really a history code for healed ulcers either, but per se, I'm trying to think if there is, may have misspoke. But again, we're doing signs and symptoms then in the outpatient world. Now, why would a patient be coming back? If you see in the chief complaint, why is the patient coming back to follow up on a healed ulcer? Just because the patient comes back and the provider is looking at it, which I would never put, I wouldn't want the provider to say that. Why is the patient coming back to follow up on skin integrity? Something like that, right? Not but if the patient is coming back because they had an ulcer and the doctor wants to check it and make sure everything's going well, if it's healed, you're not coding it as because it's not getting active treatment, and him looking at it is not active treatment. He's just saying, yeah, it looks okay. Yeah, it still looks good. Okay, so you have to understand what is happening when what are the common treatments for a pressure ulcer. If you don't know, you may not be able to determine if it's active treatment or not. And of course, we can always query the provider. These are some things that you do need to be aware of, though. Even though the pressure ulcer could have been healed, there are other complications that could have occurred, right? Let's say the pressure ulcer is healed, but these complications would be a reason why the patient would come back, or why the provider would want the patient to come back to look. Complications, which could mean further treatment if we have an infection, where we don't have a pressure ulcer, but we have a skin infection. So we need to put the patient on antibiotics. Some other things that you'll see is sepsis, cellulitis. Cellulitis is just an inflammation of the skin. They usually give you antibiotic, right? So if you have a healed pressure ulcer, nice, fresh, new skin, and there's cellulitis there, man, we want to treat that right away, because we don't want to result in another pressure ulcer. Anything that would be a problem for the integumentary system, we don't want to compromise it. Osteomyelitis, gangrene, sepsis, and arthritis. Arthritis. These are all things that could be a result. So look for that documentation. Is that why they were there? A complication, but not the pressure ulcer. Pansy makes a really good point here. She goes, the ears are also a place that get decubitus, and I have seen that too. The back of the head, and I've seen it on the side of the head, but I've seen it on the ear. Maybe patient is housebound, sedentary, sometimes happen in morbid obesity, absolutely. And those pressure ulcers are expensive to treat. Yes, they are. That's why there's organizations that only deal with pressure ulcers, and guidance and education on pressure ulcers. And we're going to give you that information there for you to look at. It's a really high protocol for hospitals as well as skilled facilities and home health with elderly people. Pressure ulcers, big, very expensive. It takes a long time to heal them. So let's go back to the guidelines for pressure ulcers. That's going to be in 1B14, and it says code assignment may be based on medical record documentation from clinician, okay, for who are not the patient's provider, for stages. So if you see that the patient, the nurse documented that the patient has a pressure ulcer stage 2 on the right heel, okay, you can use the stage and the location that, you can say, yes, we've got a pressure ulcer, you can code that, but only, it says, however, the provider still has to have the information that there's a pressure ulcer. So let's say that in the nurse's notes, you read all the information about the pressure ulcer that you need to get the proper highest specificity of the code. And nowhere does the provider state that the patient has a pressure ulcer, then you can't code it. However, if down in the diagnoses, the provider lists all the diagnoses and they say pressure ulcer. Okay, and then you go back and you look at the nurse's notes. You know, it says pressure ulcer right heel, and then you see stage 2, all this information. Then you can, because the provider has stated, yeah, there's a pressure ulcer, and with pressure ulcers, you can take that authority. The clinician is an authority, and you'll see that in OT notes and PT notes. You can accept their documentation to stage a pressure ulcer. So that is something that you could see on a test. They're not trying to trick you. The things we want to see, now this was a provider to provider, talking about documentation whenever you're dealing with pressure ulcers. We want to make sure we have consistent documentation of process in place. So that's a protocol, pretty much. And that means you're going to see every time that something is documented about that patient and they have a pressure ulcer, it's going to be noted. Somewhere it's going to be noted, okay? Then also, we want to make sure that the pressure ulcer education for the provider is given on how to document pressure ulcers and injuries, pressure injuries. Okay, that's where you become the liaison. Now, we're not telling them how to document. We're just saying this is what ICD states. That's where you're educating and being a liaison and saying, hey, by the way, with ICD, wound and pressure ulcer is not synonymous. This is the verbiage that you're going to see in our manual, and this is what we look for to get to the highest specificity. And so these are the blanks that need to be filled out. When I was at HealthCon, I went to a particular provider's lecture, and it was fantastic because he said the easiest way to work with providers is to just say, give them the magic word. So you know how we say the magic word, what's the magic word, please? Okay, they want to know, what's the magic word that I need to document that I can relate that this is what it is, that this is a pressure ulcer, that this is a diabetic pressure ulcer, that this is a wound and not a pressure ulcer, okay? So again, they don't need all that other information. You need to say, okay, if it's a diabetic pressure ulcer, then I need to see the word diabetes. I need to see PU or pressure ulcer in there. Oh, okay. But if you say wound, I'm not going to understand. I'm going to think that's an acute trauma, not a chronic. And then you could say, oh, magic words would be acute versus an acute injury versus chronic, and then pressure ulcer or whatever. And then so again, they don't need to be told how to document. They just want to know what are the magic words so that they can assist us in getting to the highest specificity, right? We're working together as a team. Location always has to be documented. Is it the heel? Is it the ear? Right? Because that definitely changes the documentation. How big is it? You'll always see measurements with pressure ulcers. What's the treatment? What are we doing to cure it? Are we putting a wound vac on there, or have we debrided it and are going to let it heal? We packed it. What do we do? Staging. So what stage is it? 1, 2, 3, 4, 5. Okay, and almost always you'll see photos, so that will accommodate that specificity for the provider, and then we can easily stage. The provider can stage the healing process and determine what is working and what's not. So you'll see that very commonly. Let's see, diabetic ulcers. Again, you're going to have a fourth character of 6 whenever you have a diabetic foot ulcer, would be E11.621. So anything past the point is going to tell you a manifestation. So if it's E11.9, that's type 2 diabetes with no complications. If it's E10.9, that's type 1 diabetes, no complications. Whenever there is a character other than 9 behind that point, that means there's a complication of some kind. And 6 is going to be for our ulcers. Notice that when we were talking about pressure ulcers, foot wasn't mentioned, but diabetic foot ulcer is mentioned here. Why do you think that is? Because when you're diabetic, it's very common to get foot ulcers. Your shoes were too tight, right? You went to Vegas and walked all over the place and developed a sore on your toe, and it turned into an ulcer because you were diabetic. Wouldn't have happened if you weren't diabetic. probably. You would have just had a blister. I got a big old blister on the back of my heel from walking all over at the conference. But I'm not diabetic. So again, it healed up really nicely. But if you develop a blister on your foot and you're diabetic, you're definitely not going to heal as fast as the blister on my heel or my foot healed. Then let's see, if we have, let's say, this foot ulcer E11.621, then we have to code additionally an L code to identify the ulcer. Right now, it's not going to be that L89 because that's just a pressure ulcer, but we do have non-pressure ulcer, chronic ulcer of the left heel, midfoot limited to breakdown of skin, L97.421. Now I can see your little coding spidey senses going on and say, wait, that's confusing. Because if it's a pressure ulcer, but it's a diabetic ulcer, how can it be L97 if L89 is the pressure ulcer code? Because L97 is non-pressure. Well, that's because if you're diabetic and you have an ulcer, a skin ulcer, it automatically becomes it defaults to a non-pressure ulcer. It probably was caused by pressure, but you're diabetic. So what caused it? The pressure, and it wouldn't have happened unless you were diabetic. The example of me walking around and getting a blister on my heel, it's just a blister on my heel. But if I, even if it ulcered, it would be a pressure ulcer, right? However, if I'm diabetic, it is not a pressure ulcer. It is now an E11.6, and it is a non-pressure. I wouldn't have gotten that. Ulcer wouldn't have developed if I wasn't diabetic. Okay, so you got to think about the disease process and how that works. Okay, let's move on. These are things that are in the real world that are going to be complicated for you. But don't worry, you're going to have mentors and you're going to have your supervisor and other people around to help you. So I went to the podiatry. Let's go back to the podiatry article, and I'm going to show you what that looks like. I've got it up over here. Things that podiatrists are going to be paying attention to when dealing with the feet: diabetic foot ulcers, pressure ulcers. Okay, so you could have a pressure ulcer of the foot and not be diabetic, right? Stasis ulcer and or arterial ulcer. Whenever you are dealing with that, any of these, if you've got a diabetic foot ulcer, it's going to be an L97 code. Right? But pressure ulcers code with L89. Stasis ulcers code with I83. For arterial ulcers, it's I70. Okay, just a heads up. You may want to make a note of that somewhere. But here is where we say, oh, by the way, our patient is diabetic. So we have an authority. You know how you've heard of coding clinic and stuff like that. This isn't the authority that came down, the NPUAP, the National Pressure Ulcer Advisory Panel. So this is such a big deal that they've got their own entity that regulates this or gives us education on this. And the great website, which I did, again, put that on the resource page. So what do you do when you have a diabetic foot ulcer? And it's also a pressure ulcer related. Okay, so the example they gave us is a patient with diabetes, PAD, and neuropathy may develop an ulcer on the dorsal proximal interphalangeal joint of a contracted second toe. So this is the second toe, and it pushed and caused. So again, this is an ulcer that's arterial, neuropathic, and pressure. Which one are we going to code for? Well, the NPUAP tells us that for ICD, that if an ulcer on the foot of a patient with diabetes, then you'd hear it a diabetic ulcer and you'd code it as L97. Okay, because they wouldn't have probably had these conditions if they weren't diabetic. Now, the other thing is that I'm stretching here. Okay, don't quote me on this, but think of the disease process. if our person is diabetic and they have PAD, it's diabetic PAD. If the patient is has neuropathy and they're diabetic neuropathy, right? So it stands to reason that if you're diabetic and you have a pressure ulcer, it's a diabetic ulcer. So that's how diabetes works. If you understand the disease process in diabetes, diabetes compromises every single body system. And you're going, unless the provider absolutely says it is not related, it is related, okay? And if the person has neuropathy and they're diabetic, it just makes the neuropathy worse, having diabetes. Pressure ulcer just makes it worse, so therefore it becomes a diabetic pressure ulcer. And if you have questions about this, then there's a link to show you this advice that comes from the NPUAP, and you can use it to help educate. Then again, it doesn't matter, even if the fact that we have the neurological system and the cardiovascular system being involved, the diabetes trumps it all, okay? So keep that in mind. All right, let's see, we got another question. Oh, those were just things that said thank yous. Well, thank you very much, ladies. I appreciate that. Now, there is a whole bunch of more information out there, but I wanted to go to the resource page. We'll come to this. We got just a couple more minutes. Here's the resource page. Like I said, that one was a great article, but it was 2009. So it predates the change in the guidelines. And as a student, be very careful when you go and look. And whenever you Google something, sometimes they'll tell you the date of the article. And if it's not going to be relevant, if it's going to be too early like this, then you want to be very careful. Now, this other article that I got some information from, here's some other links of where the original article came from. And whenever you have somebody, Tamika Davis, I've seen other stuff that she has done, and Sarah Hubert, very, very reliable resources, very educated, and RHITs and RHIA, that's always helpful, right? That means that they know inpatient stuff really well. Then again, here's the NDAY NQI. That's a pressure ulcer staging, their authorities, as well as that one I was telling you about, NPUAP for pressure ulcer staging. So I went ahead and put those links in there. I kept this a different color because I wanted you to know that that was the authority. All right, usually I just make them all the same color, but that one I wanted to make sure to highlight for you. Now let's just look real quick. Let me pull this over because I got a couple minutes left. I want to show you this article. This was the podiatry article. It was 2016, right? So again, that's important to make a note of the guidelines and everything. But I would, this is where I pulled that language, but I wanted you to see down here other things that they dealt with. Diabetic, the fifth character, what talking about location. Feet is sometimes you don't have good information on feet, okay? So let me just show you this particular picture. Now, here we have two different feet, same patient, but it's a midfoot, all right? Midfoot. Now look at the x-ray, even shows the breakdown in the integumentary system, right? Soft tissue damage shows. See that little pocket there? Midfoot, that is an area that you don't think of that could get a pressure ulcer, right? You know, but you can, especially when you're diabetic. Now there's another, also sixth character here. What we need to know, the staging. Again, that's the clinician and the doctors to do, but we need to know the verbiage, because what is two? Fat layer exposed, okay? Muscle, bone, or unspecified severity. And it may be unspecified severity because they can't tell yet until they get in and look, right? So they're not going to stage it. Now, here you notice, here is that authority again. Where did I see him? Well, here's another one, American Medical Association, podiatric. I'm not saying that right. I'm putting the emphasis in the wrong thing. I also wanted to show you down here some other pressure ulcer codes for podiatrists. Podiatrists only deal with feet. Okay. And then the staging, and then here's another one that we get a photo. Of course, we have heel, but look, this is a pressure ulcer. This is a pressure ulcer, but we can't tell the stage of that until they get in and open it up, right? This is where I told you, you touch that apple and it's gushy, right? We don't know what stage that is, but we know that the integumentary system, I've seen them when it was just looks like a black scab, and until they went into surgery and opened it up. Now this you can see. So a lot of times when they have to go in and clean this up, they'll do it in surgery, right? So again, don't confuse other and unspecified. They're saying, right? We got a heel right here, right? So that is specified. And then we have midfoot. And then this, look, that's black too. That may be all the way up into the ankle. The disease process works differently with diabetics. It seems to be much worse when you have a diabetic. And I think all this other stuff is injury codes. Remember, I told you, don't get confused with wound coding. So the podiatrist went ahead and said, okay, now this is what you're looking at when you come up with wounds, not pressure ulcers. Okay, and then there is the places where they resource to. This was it's Podiatry Today. I don't have a reason to get in there a lot and look at podiatry stuff, but feet are very unique. And if you have any questions about feet, coding anything on the feet, go look at resources for podiatry. Right? So this is linked there, so you don't have to worry about that. And let's go back to any other questions. Oh, yeah, Whitney says the patient that she talked about was in the hospital with sepsis. So yeah, that would be something that could easily be related, but you cannot code it as a pressure ulcer that related to in the hospital unless they document it. If you have any questions, make sure you can go out and ask them in your course in the club. If you're a student with Prime, we have, of course, lots of courses that you can take after the one that you're taking. If you're watching us outside of being one of our students or in our club, know that this is the resource to get more information, because they do get a lot of perks above and beyond. You're just getting a glimpse. If you're seeing us live stream, the people that we're talking about, Pansy and Whitney and stuff like that, they are definitely students. And so again, they get that prime treatment with us, and so they get the link of the resources and things. Let's see, difference between unspecified and other. Again, just recapping, is that unspecified, the doctor didn't provide the information on where it was located. Other is it's not listed. We have a list of where these ulcers could be, but there isn't a code for it. So it's an other. And we've done other education on that, and you can go find that in our YouTube channel. Right? Thanks, guys. We did good. We're getting good on this time thing. See you next time.